Yay Networks.
Welcome to another episode of Plastic Surgery. I'm Censored. I'm your host, Dr. Rady Rahban. So today we're going to have a really interesting episode. We did one episode on skin cancer, Mohs reconstruction, etc. I think we live in LA, and it would be I'd be remiss if I didn't have yet another episode on skin cancer. I'm really lucky. We have a dear friend and a Mohs expert, and we'll get into what the hell that means. Dr. Dan Behroozan. Dan, how you doing?
I'm good, Roddy. Thank you for having me.
Of course. Dan and I have known each other since high school, which is kind of unusual for most people because they move, but as Persian Jews, we never go anywhere. So we're friends with people from kindergarten, high school, college, etc. So we're very lucky to have that community, and I'm lucky to have Dan on. So what we're going to do is we're going to talk about, for a lot of people, they find all this lingo confusing, and it's important to start the definitions. First of all, Dan is a board certified dermatologist who specializes and has extra training in Mohs surgery. So let's start out with the simplest of things, Dan. What the hell is Mohs, and how do you spell it?
A doctor named Frederick Mohs, who was actually a general surgeon who invented this procedure when he was a medical student. And he was at the University of Wisconsin and decided that he wanted to start taking tumors out, and they were getting a lot of recurrences. And so what happened was he brought in the dermatologist to help him, because the dermatologists have training in reading pathology slides. And so this procedure was invented in very early on, 50s and 60s, and they used to do it over multiple days and days and days. And the surgeon will come in and remove the tissue, and the tissue gets cut into very small, thin slices, and the tissue is put onto a microscope slide. And then that slide is stained in a normal fashion like we would any slide. And then in real time, while the patient is waiting, we can look at the tissue in 3 dimensions. So we look all the way around and underneath, almost like a pizza. So we look at the sides of the tissue and underneath to make sure the tissue is clear of cancer. So this happens slowly. It's not like you can just take a piece of tissue off somebody, get it ready in the lab, and look at it within seconds. It takes about an hour to produce this process where the tissue gets cut into thin pieces so you can see it, and then it gets stained. And then I'm able to look at the tissue, and like a clock on the wall, I can see if the tissue is having cancerous cells, whether it's at 12 o'clock or 3 o'clock or 6 o'clock. And then the benefit to that is that because I did the surgery myself, I'm able to go back to just that one area and remove more tissue and repeat the process and get the patient cancer-free. Now, how is that different than when you do a surgery like this? Because you're a surgeon, it's easy. You can remove a skin cancer and have a pathologist look at the tissue and tell you whether you got the cancer out or not, right? That's easy to do. The difference is that, A, you're at the mercy of the pathologist. He may not be on site. He may be in a different place, so you have to wait for the patient to get that result. I can get that result very quickly. But more importantly, the pathologists are not trained to look at the tissue all the way around and all the way underneath. That's what we call 100% microscopic margin control. So when we're able to look at the tissue in 3 dimensions all the way around and underneath, we can ensure that we're looking at every part of that tissue, and we can ensure that we get the highest cure rates. That's really what this is all about.
So a person comes in, and let's just be simple about this, and they have skin cancer, okay? So there are 2 ways you address the skin cancer. There's a traditional route, which is we just cut it out. The key to cancer is removing all the bad stuff and leaving the good stuff. And the goal is to get clear margins, which means we get to a place where when we look at the tissue, there is an actual transition where we have good tissue at the end, which means we got all the bad tissue, right? So the traditional way of removing things is just to cut it out. And we have the luxury of removing a bunch of extra tissue. So we're like, we got it for sure. But in certain areas, and those areas being often the face, real estate is very expensive. And so we don't want to remove a bunch of crap we don't need to. And we want to make sure it's all gone. So wouldn't that be great if we actually knew microscopically, not to the naked eye? Because to the naked eye, you're like, I got it all. And then you send it to the pathologist and they're like, nope. What do you mean no? Underneath, you left some tissue. What are you talking about? And then that patient is now home and chilling, and now you got to call him back. So what you're doing essentially is taking out tumor, You right there yourself, because you have pathology background, look at the slides and go like, shit, there's still skin cancer at the 12 o'clock position. The patient is laying there, and you go and take a little more, and you look at it again, you're like, nope, still has it. And then at the end, two things have happened. One is you removed all of it because you see it in the slide, because everything now is healthy. And the other is theoretically, you've removed the most minimal amount of tissue in order to get that done. So like the eyelid or the lip or the nostril, millimeters are super important.
So let's be clear. We see so many skin cancer patients. I mean, we talk about pandemics with COVID, but skin cancer has been a pandemic for a much longer time. The incidence of skin cancer in this country is through the roof. There's 5 million new skin cancers diagnosed, a year in the US, and the overwhelming majority, 99+% of patients don't die from the skin cancers. So we are not doing Mohs surgery on every single skin cancer that comes to the door. As a matter of fact, we're doing Mohs surgery on the minority of skin cancers. So when you get a skin cancer on your back and it's something simple, we excise it, we send it to the lab. The lab will tell us we got it out, and we have the ability to take a little bit extra just to make sure we got it all out, because at the end of the day, it's on your back. Where Mohs surgery becomes powerful is one of 2 or 3 situations. A, you're in a position on the face, on the eyelid, near the nose, near the earlobe, where taking a little bit extra will make a really big difference in the way we reconstruct the patient. They might lose their earlobe. They might lose part of their nostril and get a notch in their nose. So you want to get the smallest defect as a result of removing the cancer with the highest cure rate. So when we do Mohs surgery, we can take much smaller margins, and this is a tedious process. So we take smaller margins and able to give higher cure rates. So that's number one. So if we did that on every tumor on the body, on the legs, on the back, for every common skin cancer, we would run out of time to do skin cancers in this country. We don't have enough manpower to do it that way, because each of these procedures, when you're really doing Mohs, can take hours and hours of time.
Yeah, I mean, it's just not indicated because it's not necessary.
Right. So that's the second thing I was going to say. Sometimes there's an indication for Mohs, regardless of where the tumor is on the body. What are those other indications? When you have a very aggressive tumor that's penetrating deep, or if the tumor's already recurred after you've cut it out once the traditional way, the Mohs technique is able to follow those roots a little bit better than just taking a wide margin excision.
Yeah. So I think so for anybody who's listening, that's Mohs. And Mohs is this very sophisticated process of getting high cure rates with removing the least amount of tissue. The next question is, who the hell does it? And there's a little bit of confusion. And for those of you who know and follow the show, know that I'm I'm a big stickler when it comes to training, right? Because as you know, cosmetic surgery, plastic surgery is being done by OBGYNs and ER doctors, and there's dermatologists doing boob jobs, and it's all over the place. And I think it's all at the disservice of the patients. So this alphabet soup. So theoretically, if you want to do Mohs surgery, you need Mohs surgery training, just like you would anything else. And so I know, Dan, you did an extensive amount of training. What's the distinction between the average dermatologist or a Mohs surgeon when they're doing so-called Mohs surgery?
So I'm a big stickler when it comes to this as well, Rady. You and I have a lot of background together, and we've been doing this for a while now. And look, at the end of the day, any doctor can do anything they want to do, right? You can do neurosurgery, I can deliver a baby, but we don't do that because we don't have the expertise to do that. To become a dermatologist, to do a year of training in whatever field you want, whether it's internal medicine or surgery, then you do 3 years of additional dermatology training. And then I went on to do an extra year of training in just Mohs surgery, where I did a year of training with a what we call fellowship director, where we did 15 cases of Mohs surgery a day, where we were looking slides together, and he was on my shoulder watching me do everything I did. And during that time, I get additional training in reading skin cancers, more so than I did during residency. And then I also get training in reconstruction and putting things back together once you remove these cancers. So clearly there are certain things that are beyond my ability to, and so we can talk about that as well. But there are doctors that have additional training to do these things, and we call them fellowship trained Mohs surgeons. That having been said, there are a lot of dermatologists that just don't have fellowship training in Mohs surgery that might take a weekend course and start doing Mohs surgery. And it's very sometimes easy to do Mohs surgery on a small little tumor in the middle of the cheek, but when you get aggressive pathology and perineural invasion and tumors that act a little bit more in a challenging fashion under the microscope, and you get defects that are closer to the nostril, closer to the lip, or closer to the eyelids, that experience really makes a difference. And that's why there are training programs that treat.
Yeah. I mean, naturally anyone can do anything. I'm sure I could fix the sink in my kitchen, but
Right.
I mean, I probably do a shitty job. And if it was complicated, I'd probably get lost. So let's shift gears a little bit here. And let's just talk about skin cancer in general, because I think that skin cancer right now is, as you said, it's obviously on the rise. It's on the rise because we live in a very hot world. Too, we have people who still don't take it seriously and are outside doing things without protection. So let's talk about the basics here, because the average person needs to know just the basics. What are the basic, three types of skin cancers, and sort of, if you will, what are the people want to look for? So what are the three types of skin cancers?
So there's three basic types of skin cancers. The most common type that you'll get in sun-exposed skin is the type we call basal cell carcinoma. It's the kind you would get from a sunburn. You can get them young in life. Most people end up getting them later on in life. If you have fair skin, you're more predisposed to them. Basal cell carcinomas rarely, unless they're really neglected, kill patients. They can grow, they can be locally destructive. I call them cosmetic nuisances. If you don't treat them, they will grow and they will grow and they will grow. If they're on your face and near your nostril, they can disfigure your nostril, but they don't ever metastasize. And that means they never go to lymph node, and they never kill anybody. And that word never is not 100%. There's always exceptions to the rule.
They tend to be slow growing. They tend to stay local. They tend not to go all over the place. And naturally, like all of them, you need to address them, but they're on the more milder side. So then we have what? What's next?
And then we have squamous cell carcinomas, also very commonly found on the head and neck and sun-exposed areas. But squamous cells grow a little faster, and they do have a metastatic potential, meaning if you don't remove them, they can actually go to the lymph node, and they're much more likely to cause a problem if they do that. So squamous cells we take more seriously, but the basal cells and squamous cells, if they're caught early and they're addressed whether with a local excision or with radiation or with Mohs surgery or whatever, we can talk about these other options later. There's a lot of ways to treat skin cancers, but if you address them for whatever it's worth, they're curable and they should never be an issue. Now, remember, one other thing I'll throw at you, that 50% of patients that get one basal cell will get another one in the next 5 years of their life. So people that start to get these things, it's a lifelong issue for them. It's not that they come back, but you will get more of them. That's because they've spent a lifetime of living on a yacht or on the golf course or whatever they've done without using sunscreen.
So the last one, of course,
the third one
is the melanoma group, right?
So the melanoma group is the one that we're all scared of the most because that's the most deadly kind. And if you catch melanoma early, again, it's very curable. But if you catch it late, it can be a problem because melanoma is the most likely to metastasize. And melanoma actually, although it's the smallest percentage of skin cancers in the country, it accounts for the most deaths. So melanoma's got to be caught early, but melanomas come also in multiple different kinds. Some are sun-related. Those tend not to be as deadly. But melanomas sometimes arise in moles and as new moles that look like moles. So they can actually occur in places that are non-sun exposed. So melanoma can also have a genetic predisposition more often than not. So that's why we recommend people get regular skin checks, is really to pick up those melanomas because that's where we have the biggest impact on people's lives.
Yeah. So the take-home message is that you need a dermatologist. And these things, for the most part, are curative and can be addressed, but the key to them is early catching.
Melanomas and basal cells and squamous cells, the one thing, the take-home message I would send to your audience is, listen, these things are not the kind of things that will pop up in your skin and often hurt. They're silent. They don't do anything. Oftentimes when there's a symptom, it's often too late. So you've got to catch these things before there's a symptom. The skin checks and the healthy looking at your skin, whether by yourself, by self-exam, or by a qualified doctor, can really make an impact.
So people are listening on, oh, okay, when I get this horrible thing on my face, I'll call someone. And the answer is no. Early detection means you catch it before it becomes this Goomba. And I've noticed over and over again in my clinic where I don't see skin cancer patients, but I see patients who've had skin cancer and or are in the process of it. And it almost is this thing that's like, I've had this scab, I've had this thing, it doesn't heal, it's been there, it's annoying. It started to change, it's bleeding a little. And so those are the early signs that you should say, oh, it's not just some nothing. I might as well go get it checked out. And those are the times where you want to see your dermatologist. Now, we're going to take a quick break. We'll come back. We're going to talk about skin protection. We're going to talk about getting burnt as a child. We're going to talk about tanning boots. We're going to talk about all those sort of hot topics, no pun intended. Yeah, so stay tuned for the second half. Going to be a lot of interesting information. All right, welcome back to the second half of Plastic Surgery Uncensored. I'm here with my dear friend, Dr. Behroozan, world-renowned Mohs specialist, and we're talking about skin. And we're talking about skin, and we're talking about skin cancer, and we're talking about detection, and now we're going to talk a little bit about protection. So, you know, everybody's trying to sell sunscreen. Sunscreen is one of the most commonly sold items in skincare. And, you know, there's this huge idea that SPF and more SPF, and if there's SPF 10, why don't I get 50? If it's 50, why don't I get 200? I want to get La Mer, I'm going to get so on and so forth. So let's start out with the idea of sunscreen. So does it work? Does it not work? What kind and how to apply? Okay, so let's really, Rady, start basic with this. This notion that sunscreen causes skin cancer needs to be thrown out the door. That's clearly not fit and not true. Because studies have been done with people that use sunscreen. They tend to be patients that are already getting skin cancer. And so this theory that sunscreen doesn't cause skin cancer that you might hear about is nonsense. So, I've never heard that. So that sounds pretty crazy. So wear your sunscreen. Now, when it comes to wearing sunscreen, you got to start early in life. Starting sunscreen after you get a skin cancer is like starting to brush your teeth after you've had a cavity. You want to use it before you have the problem. So we teach our kids to start wearing sunscreen usually after the age of 6 months. And 6 months usually because we want patients' immune systems kind of start working. We don't want to start putting chemicals on the skin that might absorb or irritate their skin. So 6 months is the time where you start putting sunscreen on your kids. Now, whether you're a kid or an adult, sunscreens come in 2 different flavors. And now remember, sunscreen's a whole science of itself, right? There's so many different kinds of chemical sunscreens and physical sunscreens, and I'll explain the difference in a second. And the different sunscreens you might get in the US are going to be different than the sunscreens you might get in Europe. And why is that? Because sunscreen development in the US is actually regulated by the FDA, even though it's an over-the-counter medication. But it's regulated by the FDA. So bringing sunscreen to the market in the US is a little more difficult. So we're a little bit slower to get sunscreens in the US than you might be able to get in Europe. Having said that, these days we have amazing sunscreens. And sunscreens fall into 2 categories, physical and chemical. And to make it really simple, the chemical sunscreens are molecules that you put on your skin that absorb the UV rays and the light rays from the sun and stop the rays from getting through the skin. The physical sunscreens are like shields. They just sit on the skin, and they're minerals, usually just titanium or zinc, and they just block the rays from getting through. Like a barrier. Correct. Now, in the past, people used to like chemical sunscreens because they were softer and nicer on the skin, because the physical sunscreens were big elements and they were very white on the skin. Sunscreens have come a long way, and now they both can be put on the skin very nicely. They're micronized, and they both look and feel good on the skin. The difference becomes that physical sunscreens are probably better sunscreens because they block the rays altogether, and they're probably they are less likely to cause allergies and irritation on the skin. So if you're really concerned about sunscreens, irritating your skin or causing an allergy, you stick to the physical sunscreens. And if you're not concerned, it really doesn't matter. In my opinion, they're all great. And as long as you're with a sunscreen from a manufacturer that you trust, having an SPF 30 or higher is more than sufficient for adequate sunscreen protection. Meaning a 30 versus a 50 versus a 60 will give you the same level of protection. So why do they make the 60s? Because the problem is this. In order to put on sunscreen effectively, you need to have a shot glass worth for your entire body. And most people are not doing that. They're putting it on too thin. And so when you're really putting on a 30 and you're not putting it on thick and heavy enough because you don't like the way it feels, or it's just too much work, or it's too greasy, then you're not getting a 30 really. You're getting a 15 or maybe an 8. So if you put on a 60 and you make it thinner, you might be getting more protection. But if you put on a 30 the right way and you put it on adequately, it's more than enough. So let me break this down here, because I think this is important. And I think this is really the key. My wife is a sunscreen. I mean, I don't know how to explain it. She's nuts. I mean, she puts night sunscreen at night when we're going to sleep. I don't know how else to tell you this. So God forbid, like, I don't know, there's an eclipse or something. I don't know. She's crazy that way. But what I realize, and I've read and I understand, it's not so much what sunscreen you're using, so much as how you're using it.
And how
and
often.
The fact is the sunscreen is gone in 3 to 4 hours. And so what classically...
2 hours.
2 hours. So what classically occurs is you go to the beach, you go to play tennis, you go wherever the hell you're going on a hike to Runyon Canyon. You slap on your sunscreen. Clearly, you put it on kind of shitty. It's always blotchy. It's only in certain areas because you don't like getting greasy and you don't want to get your hands dirty. And then you go about your day. And then you put that on around 8 o'clock or 9 o'clock. And somewhere around 12 o'clock, you're sweating your balls off. You're hot. And inside your brain, you're like, but I'm protected. And the reality is you're not protected at all. A, you sweat. B, it's already most of the barrier effects are gone and you needed to have reapplied it. And C, you put it on kind of shitty to begin with and half of it's off on your clothes. So it is important to get good, high quality sunblock. It is good to get high levels. But really at the end of the day, if you don't drive the car the way it's intended to drive, it really doesn't matter if you have a Ferrari. So I know that from both my wife and other dermatologists like Dan.
You hit the nail on the head. Let me just add one other thing. This is what I tell my patients. I mean, you hit the nail right on the head. I tell my patients, it's like toothpaste. Find one that you like. Use the one that you like. Use it right. And if you're going to be outdoors, you have to reapply it every 2 hours. Otherwise, it doesn't work. It's simple as that.
So there's another, these are all the interesting things that I picked up as a sort of layperson, because I think in your world, it's pretty straightforward, meaning these things all make sense, but the average person just doesn't want to do the average things. I mean, there's a reason why we have an epidemic in weight. People are obese. It's not because they don't know that if I eat a cheeseburger, I'm going to get fat. It's just about application and reality. And so some of the sciences don't affect them, but when you tell them the basics, they get it. The other thing is this idea that I'm wearing sunscreen now as an adult. The truth of the matter is that, and correct me if I'm wrong, the skin cancer you're going to get today is probably as a result of the initial really shitty burn, probably a deep second degree that you had in summer camp in 1980. And so it's not one of those things like I'm going to get sunburned this year in Bali and next year I'm going to get skin cancer. No, you're going to get burned as a kid in camp. And then you're going to go live your life. And that burn is the one that's going to lead to the skin cancer that you get at 65. So what you were talking about in terms of childhood, it really is a responsibility of the parents. And for anyone who's listening, you slap it on yourself, maybe. But if you don't do it on your kids and they go in the pool and reapply it and then wear those T-shirts and those crazy looking hats, they're going to get the skin cancer when they're 60. And really, it doesn't really matter what they apply in their 50s and 40s. Right, Dan?
Absolutely right. And I think, UV damage is cumulative, like any other damage. Like saying I smoked, for 3 years and I stopped and then I started again. You start smoking in your teens, it's going to, be an issue for you when you're later on in life. UV damage is the same way. So you need to start protecting yourself young and early, and the parents have to teach their kids early on in life. Protective clothing and shade and hats always going to be better than a sunscreen. I mean, don't kid yourself. And if you have a family predisposition, you should be doing both. Clearly, I do both as well when I go out. And these things matter, and that's where tanning booths come into play. The amount of UV damage you can get from one tanning booth exposure can lead you to get a melanoma, and so that's been studied and shown as well. So tanning booths are completely off. For me, if patients ask me should I go to a tanning booth, it's absolutely the worst thing you can do. And I wouldn't allow it at all. So that's like the worst thing you could do to your skin is go to tanning booth. So
yeah, I think one of the things that needs to be reiterated and echoed is it's the mindset. It's kind of the way we look at cigarettes today. If you think about somebody who smokes, you're like, ew, you smoke? That's gross. You disgust me. Literally 20 years ago, you were cool as shit. I mean, you were cool. You'd be outside. You'd be smoking. You were the man. And now if you're the one outside smoking, you're kind of gross. Nothing has changed other than our attitude about it. And so the attitude about skin health, you don't really have much resistance when you tell people, hey, you got to brush your teeth. But when it says, hey, you got to put sunscreen, they're like, that's kind of like, it's kind of like losery, blah, blah, blah. So you got to change the dialogue, and the dialogue occurs with your kids. And you got to keep saying, hey, honey, you want to put on the sunscreen? Hey, honey, yeah, I know you're annoyed. Get over here. You got to do it. And so really this is about a message to, yes, people, but mostly I think it's parents and teaching your kids the concepts of skincare, just like you wouldn't tell you tell your kid, honey, don't have all that sugar. It's going to rot your teeth. You would never not tell your kids that. But then the idea is like, hey, honey, you don't go outside without the sunscreen. You're going to get a melanoma. If you said that, it wouldn't be so weird.
Go outside, have fun, go to the beach, ride your bike, but be smart about it. Wear a hat, wear sunscreen, and protect yourself. Look, the places that you're most exposed is your face, right? And Rady, you sew up people's faces all the time, no matter how good you are as a surgeon and how amazing you are as a surgeon. If you remove a piece of tissue from someone's nose and you have to put it back together, there's always going to be a scar and a defect, even if you do the most amazing job. So what are the parts that stick out? The nose, the ears. I mean, you have to protect these areas the most.
Yeah, and I think it's interesting. Another way of perspective, because my goal is ultimately just to get people to do it. I don't give a shit how you do it, and I don't care why you do it. Do you know why my wife puts on 70,000 layers of sunscreen constantly? Do you know why? Do you think it's because of skin cancer? Do you think she doesn't want to get a melanoma? She doesn't give a shit about a melanoma. She's so goddamn vain. I don't care what your reason is. I don't care what your logic is. In the instance of my wife, it's because she looks at people in their 40s and 50s, and some look really good, AKA people with thick, oily skin, and some look terrible. And she doesn't want to look terrible. And she realized, because she's smart, she went into one of those photo booth things that show you the amount of damage. She freaked out. And then ever since then, she went from being, the typical young girl in their 19, 20, laying out and getting tan, because it looks good. You look good tan. And then realizing, well, shit, I'm going to make a late term investment. I'll look a little pasty, and I'll use bronzer or whatever.
And these days you can use a tanning cream, or you can go to a spray tan. Those are perfectly safe.
Or I'm going to look really good in my 40s and 50s. So, that's a choice you have to make. And I think that if the reason is you do it is because you're vain instead of because I care about skincare, great. Number one, you got to worry about your ears, nose, lips, places that stick out.
So remember, 95% of all skin cancers are on the head and neck. Right.
Your décolletage, right? You don't want that. You don't want your chest to look all crepey and nasty. So décolletage, neck, ears, nose, and lips. And then don't forget your hands.
There have been studies in the U.S. Most of the skin cancers in the U.S. on the left side of the face and the left arm, because of driving. In the U.K., it's the opposite. So you got to protect that.
For example, we got my wife tinted windows, and it makes a huge difference. She's really happy with the fact that when she's driving, she does it. So it's about making skincare practical, about making skincare realistic and doable, rather than it's all or none. I'm going to become some skin Nazi. I'm going to worry about it constantly. Or, you know what? I'm going to live my life holistically, and whatever happens, happens. It doesn't have to be all or none. You can slap on some very amazing sunscreen on those areas we mentioned. You can be conscious and stay out of direct sunlight. If you have kids, make sure you apply, and stay the hell out of tanning booths.
And I think one other thing that's important for your audience, because I think you have a lot of Latino patients still, and you have a lot of ethnic patients like I do. And I think that one message I would send also to them is that, look, just because you have ethnic skin does not mean you are protected. We do surgery on a lot of patients who are African-American, Latino patients, Persian patients, you name it. I mean, yes, you have some protection when you're brown, but it does not mean you do not get skin cancer. So the problem is in ethnic patients, because they have this feeling that, I have ethnic skin, so I'm not going to get skin cancer. The diagnosis is often delayed in those patients because they're delayed to show up at the doctor's office with the problem, and their skin cancers tend to be much more aggressive as a result when they do get it. So,
I mean, the reality is that no one is immune to the sun's damage.
Correct.
Some people have a little more protection, but the reality is that if you ignore it, whether that be from a cancer standpoint or from an aesthetic standpoint, the radiation you accumulate will ultimately do damage. And so the question you have to ask yourself, especially in a world where we're now much more aesthetically inclined and much more intelligent, is, do I want to add skin into my awareness zone as I have the other things like smoking? We don't do that anymore. Well, this is one of those things that you got to add into your things. People don't go out having, a triple cheeseburger with bacon and melted cheese without knowing that it's bad for them anymore. We can't act stupid anymore. So the question is, now you have the information. Whether you do something about it is up to you, but I assure you it's not as complicated as you think.
I mean, I tell my patients, you brush your teeth in the morning, put your sunscreen right next to your toothbrush. Make sure you don't brush your teeth with your sunscreen, and just put your sunscreen on right before you go out to work. I mean, at least put it on your face and your arms before you go. If you do a habit, start early in life, I think you will get tons of cosmetic benefits, whether it's wrinkles or brown spots and just the way your health of skin looks. And then your risk of seeing me later on in life for a surgical procedure is much lower.
Yeah. Or you can just have a crazy wife like me who puts on sunscreen on my face. Anyway, well, Dan, it was a pleasure. We will definitely have you back because there's a lot of interesting subject matters that we can discuss. But I thought skin health, skin cancer was primo, and I'm glad that you were able to help us and educate people.
Thank you so much for having me on. That was really, really nice.
Where do people find you? I'm sure you have a hashtag or something or a Twitter or
you can
website.
Find me on Instagram at Dr. Dan Behroozan or at my website at www.dermsurgery.net.
So that's Dan Behroozan, and Behroozan's Behroozan. And then the website was what?
Dermsurgery.net.
Dermsurgery.net. You got it, everybody. At any rate, it was a pleasure. Thank you so much.
Thank you, Rady.
As always, everybody who's listening, I hope that you find the information helpful. Most importantly, if you know anybody else, share, download, subscribe, all those things that my producer tells me to tell you. Join us next week on Plastic Surgery Uncensored. I'm sure whatever topic we're talking about will always be interesting.
Thank you for listening to Plastic Surgery Uncensored with Dr. Rady Rahban. We would love your feedback. If you enjoyed this episode or if you find our podcast helpful, tell us why. Leave us a review and make sure you subscribe on your favorite podcast platform. If you have a topic you would like for us to discuss in an upcoming episode, please reach out to us on Instagram at Dr. Rady Rahban, on Facebook at Rady Rahban, or at RadyRahban.com.